non-small cell lung cancer, unresectable stage 3. For these patients, our typical approach is concurrent chemoradiotherapy, and one of the most frequent standards there is 2 cycles of cisplatin etoposide concurrent with radiotherapy up to at least 60 grays in dose. One thing that remains unclear from the data that we have is that, do we need to give more cycles of chemotherapy? Do we have to give consolidation chemotherapy, in other words, after the concurrent chemotherapy, chemoradiotherapy treatment phase? And in this respect, there was a very nice phase 3 study presented here in Chicago for GILT, which is a German intergroup. It was presented by Dr. Huber from Munich. And what the group did was they for patients with unresectable stage 3 non-small cell lung cancer, they gave 2 cycles of cisplatin and oral vinorelbine in a 4-week schedule, concurrently with radiotherapy up to 66 gray. And then non-progressive patients were randomly assigned to either observation alone or observation plus 2 more cycles of cisplatin and oral vinorelbine in a 3-week schedule. The first finding was that the treatment was in general well tolerated, and perhaps important is there was little additional toxicity in the consolidation phase. So overall, the toxicity picture did not worsen much because 2 more cycles of chemotherapy were administered. In terms of efficacy, the authors noted a better disease control rate, but unfortunately this was not translated in an overall survival benefit. Actually, the median survival was 21 months with and 19 months without consolidation chemotherapy. And looking at 4-year survival rates, it was a little better with consolidation. It is 25% with consolidation versus 21% without, but this was non-significant. The authors concluded that addition of 2 cycles of cisplatin and oral vinorelbine improved disease control, but did not improve overall survival in this setting. So what does this mean for our practice? The study clearly had some limitations. It was, in this setting, rather small, be it a phase 3 study. 100 patients per arm is not really much. And the other particular thing about the study was the chemotherapy regimen. Cisplatin and oral vinorelbine is not really a standard regimen we use in this situation. So we remain with the problem that we all know that for early stage non-small cell lung cancer, we will give 4 cycles of adjuvant chemotherapy. For stage 4, we give 4 to 6 cycles of a platinum doublet. We even talk about maintenance therapy now. And then, on the other hand, we would leave our stage 3 patients with only 2 cycles of chemotherapy and even suboptimally dosed chemotherapy, because, for instance, vinorelbine, you cannot give it in full dose during radiotherapy. So this is quite unlogical. So I think we clearly need larger studies in that setting. Remember that to prove the value of adjuvant chemotherapy after resection, we needed thousands and thousands of patients. So why would we solve this in stage 3 with trials having 100 patients in each arm? Until then, until we have new data, I think it's pretty reasonable for clinicians to give 4 cycles of chemotherapy to patients with unresectable stage 3 non-small cell lung cancer at the present time. Another thing about stage 3 is that we should optimize our systemic treatment. And I already alluded to this. None of the modern regimens, like cisplatin vinorelbine, cisplatin docetaxel, can be given at full dose during radiotherapy. And this is an issue. As oncologists, we like to give the correct dose of the treatment. There are signals that platinum and p-methotrexate might be administered in full dose, and there was one abstract here at the ASCO meeting, a phase 2 randomized control trial that looked at it, and it looked at full dose cisplatin p-methotrexate concurrent with radiotherapy, followed by 3 cycles of pemetrexed maintenance, or carboplatin pemetrexed, concurrent with radiotherapy, followed by 3 cycles of maintenance chemotherapy with pemetrexed. And the findings were quite good. The tolerability of this regimen, administered in full dose, of these 2 regimens, administered in full dose during the radiotherapy, was good. Toxicity was manageable and very acceptable in this treatment setting. The trial was not meant to be comparative. It was about 50 patients in each arm. But if you look at the results, clearly cisplatin pemetrexed was the preferred one, because the outcome was better in the cisplatin pemetrexed arm. For instance, the 2-year survival rate, which was reported by the authors, was 58% with cisplatin pemetrexed and radiotherapy versus 45% for the carboplatin arm. And so this is, of course, important work, but because it's, again, the preparatory work for the large phase 3 trial, which is ongoing, comparing cisplatin pemetrexed to the standard cisplatin etoposide, a large ongoing phase 3 trial called the Proclaim trial, which almost finishes recruitment. The other possible way to improve our systemic approaches for unresectable stage 3 is the integration of targeted agents in our treatments. And there, this is, of course, this is a big dream, but just as at the ASCO 2011 meeting, here again, the results on this topic were very disappointing. And this is in large contrast with what we see in stage 4, where targeted agents really make progress for patients. The integration of targeted agents in stage 3 remains very difficult. And for instance, there was a presentation here from the SWOG intergroup trying to incorporate bevacizumab in concurrent chemoradiotherapy schedules. And the trial had lots of problems with toxicity. It had to be stopped several times by the safety monitoring committee, and it was finally closed due to low accrual. Another example is cetuximab. There was an abstract here from the Amsterdam group, and they looked at patients with stage 3 unresectable non-small cell lung cancer who were given low-dose radiosensitizing cisplatin together with radical radiotherapy, and they added cetuximab yes or no to that regimen. This was tolerable, but it didn't improve outcome for these patients. So together with what we have seen at the last ASCO meeting regarding erlotinib, it means that for our most common targeted agents like erlotinib, cetuximab, bevacizumab, the picture is still very difficult in stage 3, and we really should make a progress there. Unfortunately, it's not the case yet.